Okay, this will be your video lecture, chapter 43, OB and care of the newborn. Welcome back, everybody. Hope everybody's doing well. Let me introduce this chapter. So obviously you as an AEMT must be able to recognize the indications of emergencies related to pregnancy and childbirth and emergencies in newborns and neonates. So we're going to review a little bit of the female anatomy. The female reproductive system consists of the external genitalia, the mons pubis, the labia majora, the labia minora, the clitoris. The vagina is a hollow tubular passageway that's going to connect the external genitalia with the internal genitalia. In childbirth, the vagina serves as part of the birth canal. And this is just a diagram of the female anatomy of the vagina. You can see that. We can make special notes here. Here's the fallopian tubes, right? The sperm meets the egg inside the fallopian tube, and the goal here would be for that egg to come out and plant in the uterus. However, sometimes we know that the egg gets stuck in the fallopian tube, and as that egg gets larger, sometimes can rupture the fallopian tube. That's known as an ectopic pregnancy. Here's the urinary bladder. And you can see too here when the uterus here is enlarged with that, that's why it puts pressure on the bladder. And that's obviously why pregnant females have to urinate so much, is because of the pressure that's placed on the bladder. So the uterus is a small muscular organ. It is lined with the endometrial tissue that thickens each month during the reproductive years in preparation for the implantation of the fertilized ovum. And it's that endometriosis sometimes that actually affects the endometrial tissue as well. Here you have a diagram here of the fundus of the uterus. Here's your fallopian tube right here. The body of the uterus, the endometrium, the cervix, the vagina here. So a menstrual cycle, so that is defined where the ovaries and the endometrium undergo a cycle monthly of endocrine changes. After the uterine lining is shed, the hormonal changes influence it to rebuild. And ovulation is 14 days after the first day of the menstrual bleeding. Mature follicle ruptures, discharging ovum into the pelvic cavity near the fallopian tube. Pregnancy. If the sperm is in the fallopian tube during ovulation, fertilization may occur, resulting in pregnancy. If that pregnancy occurs, fertilized eggs ideally travel to the uterus where it's implanted in the thickened endometrium. And the corpus luteum secretes hormones that support pregnancy until that placenta is developed. And see, here we have a diagram of this. Here we have fertilization, 12 to 24 hours. 2-cell stage at approximately 30 hours. It splits into fours in 40 hours. The egg continues to travel it changes to a blastocyte approximately 5 days. And then we have early implantation, approximately 6.5 days, where it attaches to that endometrium. Fertilization and embryonic development. Fertilization, the conception, is the union of the spermatozoid and the ovum produces a zygote. And that's just what that diagram just kind of showed a second ago. 30 hours, fertilized ovum divides. 6 days, the zygote enters the uterine cavity, and the cells begin to form a blastocyst. The cells divide and they migrate. Extreme embryonic membranes form the amniotic sac. And the villi in the endometrium allows maternal blood to pass and allows fetal gas exchange. The placenta is a temporary organ of the pregnancy. Fetus attached by the umbilical cord, because obviously the placenta is delivered. That's why it's temporary. The fetal development, the first 60 days, it is known as an embryo. From 60 days gestation to birth is known as a fetus. Organs form by the end of the second month, but they continue to develop through pregnancy. Normal pregnancy, anywhere from 37 to 41 weeks. It's a 13-week trimester. Full-term infant should weigh anywhere from 3 to 3.5 kilograms or 6.6 to 7.7 pounds. It should be around 20 inches in length. And here's a diagram here of a 28-day embryo. And then we have another diagram here of the fetus near term. So you have the placenta here, the fundus of the uterus. We have the umbilical cord, right? Amniotic fluid to protect the fetus. Fetal development continues here. Most fetuses born before 25 to 27 weeks, birth weight under 600 grams or just over 1 pound, they do not survive. Those that do survive often have developmental abnormalities. Higher chances of survivability with specialized advanced medical care such as neonatal intensive care unit or NICU. Here is a chart, milestone in fetal development. Subheadings here, gestational age, approximate size, and development. I'll let you look over that. Maternal changes. So in the reproductive system, the uterus increases in size. The breasts prepare for lactation. Distended uterus and abdomen more prone to trauma. If we look at the cardiovascular system in a pregnant female, the blood volume increases roughly 45 to 50%. Heart rate increases 10 to 15 beats per minute. And the blood pressure may lower during the first 2 trimesters, returning to normal in the 3rd trimester. Hypertensive disorders of pregnancy, known as preeclampsia. If we look at some of the changes with the respiratory system, pregnancy hormones reduce airway resistance. Combined needs of fetal and mother, 20% increase in oxygen consumption, and tidal volume increases substantially. Small increases in the respiratory rate. If we look at the GI system, here we have morning sickness, nausea and vomiting in the early pregnancy stages. Gastrointestinal system slows during pregnancy, so these patients can be more prone to constipation. And hyperemesis gravidarum, this is where we have a morning sickness that's just super bad, causing a lot of nausea and vomiting, leading to dehydration. If we look at the urinary system, urinary frequency is more common. Glucose in urine, gestational diabetes. And protein in urine can lead to preeclampsia. The musculoskeletal system, relaxin causes the joints to loosen, and this can lead to sprains and joint injuries that occur more readily. Relaxation of joints contributes to low back pain in of pregnancy. Labor and delivery is definitely a complex interaction between hormones and mechanical stress on the uterus. A level of oxytocin increases to the point where contractions are regular and sustained. So oxytocin is that is what is introduced to cause pregnancy. It's also can be given as a medication to induce pregnancy as well inside the hospital. Braxton Hicks is contractions. This is late in pregnancy. It's intense but painless tightening of the uterus. So if we look at the stages of labor here, stage 1, dilation stage. This begins with the onset of regular contractions and ends when the cervix is completely dilated. The fetus descends further into the pelvic area, and contractions are 10 or more minutes apart, and they increase in frequency and intensity. Amniotic sac at this point in time can rupture. And so we have a diagram showing the first stages of labor begins with those regular uterine contractions and ends with the complex dilation of the cervix, and this is stage 1. So let's look at stage 2. This is the expulsion stage. This begins with the complete thinning and dilation of the cervix, and it's going to end when the fetus is completely emerged from the birth canal. Parturition, expulsion of the fetus through the birth canal. Crowning, the fetus scalp is visible at the vaginal opening when seen. Delivery of the head is usually imminent. And then the fetus shoulders and the body smaller than the head. So here we have another diagram. This is the second stage of labor begins with the complete cervical dilation and the thinning, and the ends with the expulsions of the fetus. Stage 3 is the actual placental, the delivery of the placenta. Delivery of the fetus, neonate, or newborn through the delivery of the placenta. Detachment and expulsion of the placenta accompanied by blood loss. And it's up to 500 milliliters of blood loss during a normal delivery. Stage 4 starts with the expulsion of the placenta and ends 1 hour later. So most sources only discuss 3 stages as they are most relevant to out-of-hospital care. So if we look at the fetus does not breathe air into the lungs filled with fluid. Fluid is expelled as the fetus goes through the birth canal, taking air into the lungs for the first time, resulting in changes in pulmonary pressure. During prenatal life, blood receives oxygen and from the mother's circulation. The umbilical artery carries deoxygenated blood containing high carbon dioxide and waste levels from the fetal circulation through the umbilical cord, allowing gas exchange. The umbilical vein passes through the liver, where blood enters hepatic circulation to deliver nutrients. And this is just a diagram recommending that 2 ultrasounds are recommended as part of routine for prenatal care. This is a diagram. It's listing the fetal circulation, bypassing the pulmonary circulation. And this is basically how the child breathes while in the womb or the birth canal. Anatomy and physiology review continues here to compensate for the differences in oxygenation. The fetus has fetal hemoglobin adapted to lower oxygen environment. When that circulation through the umbilical cord ceases, as the cord is clamped, Blood bypasses the umbilical arteries and continues through the iliac arteries. The neonate. At birth, the infant is wet and slippery. The head is elongated, very large in proportion to the body. The bones of the skull are thin and they're separated by membranes called fontanelles. And acrocyanosis may linger as respiratory cardiovascular systems adjust. These signs you need to remember. Need to remember what the normal heart rate is for a neonate, 100 to 180 beats per minute. The normal respiratory rate, 30 to 60 breaths per minute. The normal systolic pressure, 70 to 90 millimeters of mercury. The normal body temperature, 98 degrees Fahrenheit to 100 degrees Fahrenheit. Developmental priority is given to organs that must be most functional at birth. And immature systems can result in severe complications. The neck is short. The tongue is proportionally large. Diameter of the airway is smaller in a funnel shape. The nose is small, flat, soft. Neonates are nose breathers. And respiratory failure arrest can ensure quickly from a respiratory distress. So when we're doing the scene size up or responding to the call for the pregnant patient, remember that domestic violence is not uncommon during pregnancy. Look for indications of hazards of violence. Do not assume obvious pregnant patient has a chief complaint that might be directly related to pregnancy. In your primary assessment, if unresponsive and not breathing, normally check the carotid pulse, begin CPR if no pulse is detected. If unresponsive but breathing, ensure that we have an adequate airway. Causes of hypotension in third trimester would be supine hypotensive syndrome. This is where the baby is positioned over the inferior vena cava. Uterus compresses inferior vena cava, and it reduces blood to the heart, decreased cardiac output. Here's a diagram outlining the supine hypotension syndrome. So you have the vena cava here, and it's just put pressure on it. Blood can't return back to the right side of the heart. In your secondary assessment, perform a rapid medical exam or rapid trauma exam if the patient's critical. If the patient's not critical, perform a focus exam according to the chief complaint. Perform a detailed head-to-toe for your critical trauma patients and your critical medical patients to whom problems not identified. Internal examination of genitalia not performed in the pre-hospital setting. We don't do that. Reasons for inspecting external genitalia. You suspect trauma to the external genitals, maybe cause significant hemorrhage that can be controlled by direct pressure. And check for perineal bulging or crowning in active labor or indications of imminent delivery. So you want to look to see if there's crowning. You want to obtain a complete set of vital signs, medical history, along with their OB history. If the chief complaint indicates labor, additional questions are going to be required, like number of pregnancies, that's your gravida, number of times given birth, number of pregnancies that did not result in birth, right? So that could be your miscarriages or abortions. Ask whether the patients receive prenatal care. We want to ask about problems with current and past pregnancies. Determine the date of the last menstrual period. Ask about fetal movement. Do the baby feel active as normal? And then a sample history with the chief complaint. Clinical reasoning process. Pre-existing medical conditions can be aggravated by pregnancy. New problems can arise during pregnancy. altered mental status, seizures, hypertension, abdominal lower back pain, vaginal bleeding or discharge, leaking amniotic fluid. All of these could be indicators of pregnancy-related problems. Patients with pregnancy complications and neonates in need of resuscitation require specialized care. And consider transport destination carefully, need for ALS transport or even air transport. We just need to make sure if we're taking these patients to a hospital that it's the right hospital, one that has labor and delivery services. If medication is required, benefits of treating mother must outweigh the risk of the medication. Rich vascular supply means many complications of pregnancy and childbirth accompanied by hemorrhage and may result in hypovolemic shock. Hemorrhage with obstetrical emergencies cannot be accessed and controlled by direct pressure, so you should anticipate shock and be prepared to treat it. So how are we going to treat it? Well, we're going to manage the airway, ventilations, oxygenation. We're going to avoid supine hypotension syndrome by positioning that patient tilted slightly on their left side. We're going to start IV access. We're going to keep the patient warm. And the patient's conditions may change quickly and maintained during ongoing assessment. Let's talk a little bit about ectopic pregnancies. This is where the fertilized ovum is implanted and begins to develop somewhere other than the endometrium within the uterine cavity, most often in the fallopian tube. So what are some of the risk factors? Well, scarring of fallopian tubes from prior pelvic inflammatory disease, PID, endometriosis, and some forms of contraception. Unless condition is recognized and managed surgically, fallopian tube ruptures with hemorrhage can be fatal, and they are. We used to say, abdominal pain in female patients of childbearing age should be considered possible ectopic pregnancy until proven otherwise. Chief complaint would be lower abdominal pain, maybe a syncope. That syncope usually can be tied into hypotension. Patients in hemorrhagic shock from ruptured ectopic pregnancies may not exhibit tachycardia. Abortion is a termination of pregnancy from any cause prior to the 20th week. A spontaneous abortion is known as a miscarriage. Stillbirth pregnancy terminates spontaneously after 20 weeks without survival of fetus. Lower abdominal cramping, vaginal bleeding, hemorrhage can be severe enough to result in hypovolemia. Threatened abortion, cramping, and bleeding occur in early pregnancies where pregnancies are maintained. Induced abortion, therapeutic abortion when medically necessary. So what they're talking about, like a spontaneous abortion or miscarriage, usually it's found early on in pregnancy, somewhere around the 23rd, anywhere from 0 to 23 to 25 weeks. And then what they have to do is something called a D&C, where they go and remove all of the tissue out of the cervix. Complications, immediately or delayed hemorrhage and infection like endometriosis. Assess for hypovolemic shock. Ensure the airway, ventilation, oxygenation, IV fluids according to your protocol. And provide emotional support, because miscarriages can be very emotional. Gestational diabetes. So patients without a history of diabetes may develop gestational diabetes during pregnancy and increased risk of complications to mother and fetus. Higher risk of this is patients over the age of 35, obese, a family history of diabetes, history of stillbirth, altered mental status. So in this case, we make sure we check a blood glucose level, hyperglycemia, untreated diabetes, nausea, vomiting, abdominal pain, thirst, and increased urination. And hypoglycemia can lead to seizures. So, manage the airway, breathing, circulation, start an IV, give some fluids, especially for your hyperglycemic patients, because these patients tend to be very dehydrated. You can administer oral glucose to that conscious patient who can maintain their own airway. And if the blood glucose level is low and the patient has an altered LOC, this is when we're going to administer IV glucose. Hypertensive emergencies, so preeclampsia, progressive disorder that can progress to eclampsia, increase in 30 millimeters of mercury in systolic blood pressure, or an increase in diastolic blood pressure of 15 millimeters of mercury, sustained across two readings at least 6 hours apart. So that would be your definition right there of preeclampsia. Suspect preeclampsia when the blood pressure is 140/90 or higher without baseline from earlier in the pregnancy. Maternal vasospasms raises blood pressure and decrease placental circulation. Protein in mother's urine can lead to preeclampsia or edema. And signs and symptoms of preeclampsia progression are going to be headache, visual disturbances, and decreased urine output. If you suspect preeclampsia with edema, sudden weight gain, visual disturbances, pain in the epigastric area, or right upper quadrant of the abdomen, headache, and seizures. The onset of seizures or coma marks transition from preeclampsia to eclampsia and higher maternal and fetal mortality. Chronic hypertension, blood pressure elevated before pregnancy or early in the pregnancy or persist after pregnancy. Transient hypertension in labor or immediately after delivery usually resolves within 10 days. All right, so we're going to manage the airway. We're going to make sure we have supplemental oxygen. We're going to make sure the mother's right in the left lateral recumbent position. We're going to start an IV, and we're going to keep an eye on that blood pressure. Keep the patient calm. And we're going to ALS ground transport or air if you're in some other area other than ours. And specialized facilities with advanced OB capabilities and neonatal intensive care being available. Let's talk about placenta previa. That would be the implantation of placenta proximity of directly over the cervix, partial or complete, bleeding during cervical dilation or labor, and it interferes with the delivery. When detected, cesarean section should be scheduled, and neonates cannot be delivered in the field if the patient has placenta previa. Bright red vaginal bleeding that's usually painless can be a clue that the patient is suffering from placenta previa. We're going to transport this patient left lateral recumbent, provide some oxygen, start to get your IVs going, and transport without delay. And see, what you see here is where you have the placenta that's actually blocking the vaginal canal here. So that would be a total placenta previa, and a partial placenta previa would just be blocking half of that, or a little more. Placenta abruption. This is where placenta prematurely detaches partially or completely from the uterine wall, compromising fetal perfusion. This condition is life-threatening for both the mother and the fetus. Fetal mortality 20% with lesser degrees of placental separation, 100% with complete separation. Increased maternal age, multiparity, hypertension, trauma, and cocaine all increase the risk. Here we have a diagram of an abrupto placenta and how it separates. And this would be a partial separation. And this would be a complete separation. And so marginal separation, vaginal bleeding, often no pain. Central separation, bleeding, trapped by attachment of placenta at the edge. Sudden, sharp tearing pain with abdominal rigidity. Complete separation, massive vaginal bleeding, and hypotension. And left lateral recumbent position is where we're going to place the patient, oxygen, IV access, and we're going to treat for hypovolemic shock transport. Trauma in pregnancy, again, so motor vehicle collision, falls, domestic violence. Position and increased vascularity of the uterus, particularly beyond 20 weeks gestation. Increased risk of serious maternal injury and hemorrhage. The fetus jeopardizes maternal hemorrhage, placental abruption, premature labor, uterine rupture. So we should anticipate shock on the mechanism of injury. Never transport patient in third trimester in a supine position. We want them not to be like that. So signs and symptoms of labor, we have Braxton Hicks contractions, increased level of pregnancy hormones and vaginal secretions, loss of the mucus plug 24 to 48 hours, bloody show, discharge of blood-tinged mucus, and lightning, which means the fetus drops lower in the pelvic cavity. Contractions of active labor are regular and they increase in intensity. If the water breaks, determine if it was clear or yellowish or greenish in color, indicating the presence of meconium. Meconium is content of fetal bowel. If aspirated to the neonate's airway, it can cause respiratory distress. Deciding to transport or to prepare for delivery. Assess whether delivery is imminent. So the indication, mother is in the second stage of labor. Mother feels the urge to bear down or push. The perineal is bulging or crowning. If the decision to deliver at scene, request additional personnel. Don't do it just you and your partner. Get some help. If decision to transport mother, continue to monitor for indications of imminent delivery. If you must deliver in the back of the ambulance, stop the ambulance in a safe place. Keep the doors closed, so that the compartment will stay warm and the patient can maintain some privacy. And if delivery is complicated, don't even wait around, get to the hospital. If crowning, be prepared to gently place a gloved hand over the head to prevent the explosive delivery. Uncontrolled explosion can increase severity of trauma to the mother's peritoneum and also injure the fetus. Use correct positioning to help the fetus to clear the pubic bone. Preferably supine with someone to help her elevate her head and shoulders to push. You want to put the mother's hips and knees in a flexed position. You want to place a drape or towel beneath the patient's buttocks. Have equipment you need, prepackaged OB kit. If time permits, start an IV. And Mr. Mother, this is the contents of a OB kit. Assist him with the delivery. As the head emerges, gently place that gloved hand over to prevent the explosive delivery. When the head's fully delivered, tell mom to stop pushing. Check to see if you have an umbilical cord that's wrapped around the infant's neck. If possible, try to slip it over the infant's head and shoulders. Otherwise, clamp the cord in two places about 2 inches apart and cut the cord between the clamps. With next contractions, gently guide head downward to facilitate the delivery of the upper shoulders. Do not use force. So we're going to let the mother do that. We're not going to add force to it. And we'll gently guide the head upward to facilitate the delivery of the lower shoulders. Once the baby completely emerges, keep the level with the vagina until the umbilical cord is clamped. You're going to place an umbilical clamp about 10 centimeters or 4 inches from the baby, and a second clamp about 5 centimeters or 2 inches further away from your first clamp. Cut between the two. You want to wipe the baby's face to clean away blood and mucus. Dry the baby and use warm blankets if we can, and allow the mother to hold the baby. Record the time of birth. Assign an EMS provider to assess and care for the baby. Obtain the appropriate APGAR scores in 1 and 5 minutes. And contractions will begin again after delivery to expel the placenta. That's a diagram of crowning. Head delivers. Body delivers. Grasp the newborn firmly. You can clamp and cut the umbilical cord. And then the delivery of the placenta. Clean, dry, and stimulate the newborn. Administer blow-by oxygen if needed. Do not pull on the umbilical cord to speed up the expulsion of the placenta. Place the placenta in the biohazard bag. Transport it with the mother for inspection and disposal. If exists bleeding, perform fundal massage. And this is a diagram of how to do that. After the delivery, inspect the mother's peritoneum for lacerations. Place a sanitary pad over the peritoneum. Reassess vital signs and monitor amount of bleeding during transport. Preterm labor, onset of labor prior to 37 weeks gestation. Complications related to immaturity of organ systems and low birth rate. The goal here is to stop preterm labor to allow the fetus to develop as much as possible before delivery. AEMTs do not administer tocolytics. Administer of IV fluids with medical direction may stop premature contractions. This is a picture of a newborn. Abnormal presentations. Let's talk about breech positions, either buttocks or both feet presenting first in the birth canal, an increased risk for maternal and fetal trauma, fetal hypoxia, compressed or prolapsed umbilical cord. The body usually delivers easily. Shoulders or head may be a little more difficult to deliver. Position the mother for delivery with buttocks on the edge of the bed and knees close to the shoulder. A breech position. So if breech presentation, support the legs and body as they emerge, but do not pull on them. If the head does not deliver, but the baby begins to breathe, slide your index and middle fingers into the vaginal opening to create a V around the baby's nose and mouth to allow him to breathe. Rarely does an arm or leg is presenting part cannot be managed in the pre-hospital setting. Transport without delay if that happens. A prolapsed umbilical cords emerge before the presenting part of the fetus. The pre-hospital goal here is to prevent the cord from being compressed. Mother is in knee chest position. Insert 2 fingers into the vagina and lift presenting part of the infant off cord. Apply oxygen by non-rebreather mask. Cover exposed cord with sterile moist dressing and transport without delay. All right, and then we should have shoulder dystocia. The baby's shoulders are larger than its head and become lodged between the mother's pubic bone and the sacrum. Associated with very large fetuses, head delivers normally, then retracts back into the birth canal. We're going to prepare for immediate transport. Your mother lie with the buttocks on the edge of the bed. Pull the knees back as close to the shoulders as possible. Use your open hand to apply firm pressure just above the pubic bone. If delivery does not occur, initiate transport without delay. A precipitous delivery occurs within 3 hours of onset of labor. The risk increased maternal and fetal trauma. Multiple births, frequently premature. They're smaller than the single birth of one infant. One presents in normal head down position and the other in a breech presentation. Deliver the first infant, clamp and cut the cord. Deliver the second infant. There may be 1 or even 2 placentas. Uterine rupture, the tearing of the uterus that may occur during labor as a result of trauma. Maternal and fetal mortality is high. Extreme abdominal pain. Uterine contraction, stop hypovolemic shock common. And pain may decrease if rupture is complete. Uterine inversion occurs rarely. The risk increased by pulling on the umbilical cord in an attempt to speed delivery of the placenta. The uterus is turned inside out and pulled through the cervix cavity. Hypovolemic shock is likely. Transport without delay. Cover exposed tissue with moist sterile dressing and consult medical direction. Pulmonary embolisms can occur anytime during pregnancy or even after delivery. More common in the patient who has had cesarean sections, and treat as you would any other patient with a pulmonary embolism. Let's talk about neonate assessment and management. At birth, neonates wet and slippery, and they can easily become hypothermic. Assess the needs for resuscitation. Maintain that body temperature to improve respiration and heart rate if needed. Routine care. Suction excess secretions. Drying, keeping warm. Tactile stimulation improves respirations. This is the inverted triangle. You can see the medications right here, we don't do a lot of those for the peds. We don't do a lot of drug therapy for them. All right, you're going to determine the need for resuscitation. Do not require resuscitation. Full term gestation, crying or breathing, good muscle tone. The table for ABGAR scoring. So on the ABGAR score, most newborns score between 7 and 10. Scores between 4 and 6 are moderate distress. Scores of 3 or less, severe distress that requires back valve mask ventilations. Heart rate below 60 and does not respond to ventilations is when we would start chest compressions. Hypoxia is the most common cause of bradycardia in newborns. So assessing the vital signs, the ideal heart rate for a neonate is 140 to 160. The strong cry indicates adequate respirations. The respiratory distress, grunting, subcostal, intercostal, or supracostal retractions, seesaw respirations. The pulse ox recommended when the resuscitation is anticipated. The temp should be anywhere from 98 degrees Fahrenheit to 100. And you're going to dry and stimulate that newborn, wrap it in a blanket, cover its head. And if the blood glucose level is below 60, you're going to talk to medical control about how they want to handle that. The oxygen administration, the goal here is to maintain a pulse ox of 96%. Long-term administration of high concentration of oxygen can cause complications in newborns. Hypoxia is the primary reason for neonatal bradycardia. Use blow-by oxygen. Do not administer oxygen directly by mask or cannula. Do not use battery-powered or fixed electric suctions in neonates. Consider neonate or pharyngeal airway for prolonged ventilation. Use the laryngeal mask or the LMA if ventilation by face masks is not effective. And use neonatal BVMs only. Chest compressions initiate if the heart rate is less than 60 beats per minute and has not improved after assisted ventilations with supplemental oxygen for up to 30 seconds. Use compressions to ventilations ratio 3:1 at a rate of 90 compressions and 30 breaths per minute. Fluids and medications. Medications rarely used in newborn resuscitation. 2 milliliters per kilogram of 10% dextrose, IV or IO, may be indicated during post-resuscitation care. 10 milliliters per kilogram IV or IO fluid infusion. Avoid rapid infusion to prevent brain hemorrhages with premature newborns. Prematurity, neonate born prior to the 37 weeks. Neonates is not considered viable until 24 weeks with a gestation and weight of around 450 grams. Resuscitate any newborn delivered after 20 weeks unless death is obvious. So these patients require specialized care in the NICU. Their lungs are underdeveloped. Fat deposits are inadequate to maintain the body temperature. Thermoregulatory mechanisms is immature. Glycogen is stored are inadequate. And the brain is less protected. So airway abnormalities, ceconal atresia, rare defect, complete blockage of both nares. A cleft lip or cleft palate is an airway makes airway management difficult. And defects of the abdomen, congenital diaphragmatic hernia, abnormal openings in the diaphragm, and allows abdominal contents to migrate to the chest. Defects of the abdomen, gastroschisis, abdominal wall defect, abdominal contents extrude through the abdominal wall, and omphalocele, organs contained within translucent sac outside of the abdominal wall. Defects of the nervous system. So we have a meningocele. I don't even know how to pronounce that. I'm sorry. Forms of spina bifida. The meninges exposed over the lumbar spine may or may not contain portions of the spinal cord. That's it. All right, I'm going to post the video, and we'll look forward to seeing you guys soon.